My name's Andrew Price, and I'm one of the consultant knee surgeons here at the Nuffield Orthopaedic Centre. I'm lead consultant of the hip and knee group, so that's representing 11 consultant surgeons. It's a great pleasure to work with. I represent them. I'm also a reader in musculoskeletal science at the Botman Institute, so I have a big research programme working very closely with people like David Murray. And I'd like to take this opportunity to first of all thank you for all coming. Thank you for being involved in our research. It's very important to us that you are. And I want to talk to you a little bit about treating early osteoarthritis. And I'm a clinical scientist, and what that means is that for part of the week I do knee surgery, and other parts of the week I assess the outcome of those types of interventions on patients with clinical trials, and I also undertake basic science research trying to understand how we can do those things better, and that's very much the same as someone like David Murray, who will speak to you later. That's a very common pattern for clinical scientists working in this hospital. And my particular interest is in cartilage disease in the knee, and I want to talk to you a little bit about treating that problem. This could have been a huge list. I put up some of the people I work with here, and I'll have to thank them all for helping me with the work that I do. And I think it just demonstrates how this is one big group of people all trying to work together for the benefit of our patients. This is a slide which is, I always think, very striking, and it shows you how common osteoarthritis is. And if you look at the graph, without really looking at the detail in too much, that bottom line is the expected increase in the amount of hip replacement surgery there will be over the next 30 years, or 20 years now. And that's hip on the bottom line. Compare that to the exponential increase in the expected numbers of knee operations because of the increasing burden within the community of osteoarthritis of the knee. So this is a huge problem that we face. Now this is a patient with very, very severe end-stage arthritis, and that patient can look forward to a successful outcome with this type of intervention. This is a total knee replacement, and David Murray is going to tell you a little bit more about some of the work we do in trying to develop this form of treatment. It's very successful, but we're trying to make it better. It's a different matter if you're trying to look at patients, younger patients, and I use the word younger very, you have to be very careful how you describe people when it was young, but I'm talking of anybody between 18 to say 40, 50, the sort of people who traditionally were not getting joint replacement surgery. So I just wanted a little overview that you get an idea of our knee research program. And really we're trying to look at aspects of problems with the knee right from the earliest point where you have the first bit of joint pain because of your osteoarthritis, right the way through to your late stage osteoarthritis where you have your joint replacement. And that means the first stages of degeneration, can we treat that? When you have an established isolated defect, can you treat that? When the disease is only in one compartment or part of the knee, can you treat that differently than if it's the whole of the knee? And David will touch on those things later on. I want to home in on these cartilage defects and early degeneration. So here's an example of a patient with a cartilage lesion in the knee, and if I could just do this, this is an MRI scan, and you can see how there's this white lesion which is affecting the bone and the cartilage within the joint. And the X-ray nicely demonstrates how it looks like there's been a bite out of the femoral condyle. It's not an osteoarthritic joint, but it will become one eventually. Sorry. If you look inside the knee with a camera, that's what you'll see. And this was a 35-year-old patient who had had traumatic lesion to their knee, and this produces significant amounts of pain and disability. And we've really struggled over the last 20 to 30 years to know how to treat these types of problems in the younger patient. Joint replacement is now a successful operation for people in their 50s, 60s, 70s, but as you approach in your 30s and 40s that time, that sort of time period for intervening is a real challenge for us still. It's partly to do with this intricate structure that cartilage is. And you can see this is the knee cap, this is a cross-section, and this is the bone, just here, and here is the cartilage, this white. And it's a remarkably beautiful material that is specialised for weight bearing. And when it becomes damaged, it's very, very hard to repair it. It's a cross-section with a scanning electron micrograph showing the cells, these are chondrocytes within the cartilage. And trying to reproduce this structure is one of the challenges that we have in cartilage repair. Now, lots and lots of techniques have been used over the years. Drilling cartilage and bone grafts that you borrow from other parts of the knee. Implanting cartilage cells is something over the last 10 to 20 years, or say 10 years would be fairer, has really become something which is an exciting and now established treatment. And I want to talk to you a little bit about this type of intervention, which I introduced here to the Orthopaedic Centre, that we're now growing in our reputation and the number of these procedures that we do. So this was called autologous chondrocyte implantation, invented by a Swedish surgeon, Lars Peterson, where you borrow a bit of cartilage from a patient's knee, take it out into the laboratory, grow it into a larger piece of cartilage, and then replace it back into the patient. And the schematic just shows how you do that in some of the technical parts of how you go about the implantation process. This was a new technique, it's evolved. This is the second generation of autologous chondrocyte implantation techniques. In introducing any new technology to the hospital, there are a lot of hurdles to try and pass over. And that's important because these sorts of new technologies need to be assessed, need to be shown to be effective, and need to be the introduction to be regulated. So there was it was 9 months of work before you could start doing this type of procedure. The first case was on the 20th of May 2005, and I asked the patient if they would allow me to show some pictures. Here's a cartilage defect in the knee. Here I'm filling it with a collagen membrane, and then we're injecting 20 million chondrocyte cells which have been grown up in the laboratory into the knee. There's the final graft. Now, that patient did extremely well. It's now 4 years out since their first operation. This is just a graph to demonstrate that when we assessed this, that we could show that the majority of patients were doing well. So the grey bars are how much pain you had before the operation, and the blue bars are the amount of pain you had after the operation. So in general, most people improved significantly the amount of pain that they had in their knees. Their pain decreased.